بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this scientific event where I'm sure that it's going to be a very added value for all of us to highlight our updated data and sharpen our experience in a very important topic that is related to the infectious disease. And of course, before I start, I would like to thank the Saudi Society for Family and Community Medicine for having this scientific event under the umbrella of the prestigious society, which has been working very hard for the past 3 decades to enhance our capabilities as a physician to be in a competency to defend our community and to establish the well-being for our society. So as you know, our transformations have a vibrant society, thriving economy, and ambitious nation. So we started by vibrant society. It means that we are working for the best interests of our society and our community and our nation. So we would like to have healthy people. They enjoy the complete state of physical, mental, social, and spiritual well-being, and not only having no disease or infirmity. So this is our role. And being, in fact, as a primary care physicians, where I'm proud to be one of you, we have been appointed to be the gatekeeper of the healthcare system, the first contact with patients. And we look into the patient in total. And unfortunately, the healthcare system has fragmented the human being within the complicity of the healthcare system into different organs, systems, particles, and parts. So our healthcare system globally, not only nationally, is an organ-oriented department. So what is our role as a primary care physician? To integrate all these parts and to put it in its own format and the human being format and pay respect, and on top of it, deliver the things that is needed. And in fact, we have delivered not only the curative medicine, but we are also providing our patients with a basket of services, which is preventive, curative, and rehabilitative. So this is our role, ladies and gentlemen, to work for the best interests of our organizations and our community and our nation. So before I start, I would like to thank Pfizer for giving us this wonderful opportunity to be tonight together. And I would like to thank Fexus for the wonderful organization. And before I start, I would like just to pave the way and set up the stage by saying that we all remember the pandemic of COVID-19. It was one of its kind globally, that no other infection hit the globe the way the pandemic of COVID-19 had hit all the healthcare system. And we have been finding that huge and highly sophisticated healthcare system are collapsing one after another. Why? Because we were not prepared to have this kind of infectious disease pandemics. We always focus on non-communicable disease, hypertension, diabetes, and dyslipidemias, and cardiovascular disease, and so forth. But we don't pay much attention on the return of the dragons, which is the infectious disease like COVID-19. And we remember that millions of deaths and millions of hospitalizations, and there was a global and national shutdowns of all the activities. But here, different countries came with different strategies. Countries that focus on economy, which totally collapsed, and countries which focus on the well-being of the human being, which thrives and survive, like what we have done. So, however, there was a wise man said once, the world will never be the same after COVID-19. And this is exactly what happens, ladies and gentlemen. We have witnessed that we have learned the prevention much more than any time, much more than ever. So we started implementing the preventive services in terms of acceptance of vaccinations because it was mandated for us to have the vaccine for COVID. And we have reached the herd immunity for the first time, never had been reached before. Not only this, but also we have learned certain skills, how to prevent the infection to be spread. So the social distancing, the use of sanitizations, and even the etiquette of cough and sneezing. We learn a lot of things. And of course, this has been impacted our soon recovery from the pandemic in no time with a very less devastating consequences. So, but the question, ladies and gentlemen, today is the pandemic is over? Yes, it is over, but COVID-19 is still there. And of course, as you know, in our society, we have certain people at risk. We have elderly populations, we have people with multiple comorbidities, so they constitute this kind of risk, and they have a high susceptibility to have this kind of infections. As you know, the year 2045 is a crucial year for all of us. Why? Because in this year, we are going to double our populations in the Kingdom of Saudi Arabia to reach 72 million people. And the same year, we are going to have the highest level or the highest evidence or prevalence of chronic disease, like hypertension, diabetes, obesity, smoking, and so forth. Of course, these confounders subject, and even the life expectancy of our populations, it will reach up to 81. Now we are talking about 78 years of age, but in those years we are going to reach 81. So we are going to grow older, and we are going to carry along with us a lot of comorbidities, and definitely majority of our populations will represent the elderly populations rather than the young population that we have today. So definitely we have to prepare ourselves very well, and we have to make sure that we are well equipped with the knowledge and the skills and the vigilance enough to witness this kind of threat that is coming. So, as I said, our role as a family physician and primary care physician is very important. And I think it's that today we are going to shed a light on the COVID-19. And we have been privileged to have two of our eminent speakers, Dr. Mohammed Samanoudi and Dr. Tarat Al-Misani. They are eminent figures and experts in the field. So without any further ado, ladies and gentlemen, because I would like to give enough time for our speaker to enrich us with updates. So I would like to introduce Dr. Mohammed Samanoudi. Dr. Mohammed Samanoudi is Assistant Professor, Al-Qura University in Mecca, and he's a consultant of medicine, infectious disease, and transplantation infectious disease in King Fahd Armed Forces Hospital in Jeddah. So he's going to talk to us about the Paxlovid, the new approach to outpatient treatment for COVID-19. And I would like to remind you, be ready with your questions. You can write it down, or you can have the mic to deliver your questions to the speakers, or even you can, for the online attendees, they can send their questions through the Q&A box, and then we'll be able to send the question to our speakers. The next speaker will be Dr. Tarat Al-Misani. He will be joining us virtually online. So I would like, on your behalf, ladies and gentlemen, to welcome Dr. Mohammed Samanoudi. Dr. Mohammed, the floor is yours.
طيب السلام عليكم مساء الخير الجميع. In the beginning, I would like to thank the Saudi Society of Family Medicine and Pfizer and Fix for their kind invitation. Today we're going to talk about, it's a kind of old topic, but we are going to have different flavors today on that, and hopefully everyone will enjoy with us today. I think Dr. Ashraf, we didn't meet for a long time. So in that duration, I became an associate professor now of infectious disease in Al-Qura University. So, you know, in the beginning, I would be sensitive of saying assistants, but after that, it's okay. Okay, all right. Bismillah. So our talk today about Paxlovid, the new approach for outpatients treatment for COVID. So we will go through like different concepts in the outpatients and how we select those patients for the nirmatrelvir, ritonavir, or the Paxlovid to use the max benefit for those kinds of patients. So let's go. So the presentation was made by the help of Pfizer representative, Ms. Reem Al-Mansouri. Okay, so our contents today, we are going to define who are the people at risk to progress for severe COVID. What is the indirect effect of severe COVID on the high-risk group? Antivirus underuse and antibiotic overuse, and early detection and treatment to prevent the progression to severe COVID, Paxlovid clinical trial data, and the Paxlovid real-world evidence. So COVID-19 is an enduring global public health issue and ongoing. So as Dr. Ashraf said, the pandemic is gone, but we still have COVID around us. And we have a lot of mutations, ongoing mutations, a lot of mutations that makes the COVID sometimes more aggressive, sometimes more aggressive to distribute or to spread between us. And we have a high-risk group that we are worrying about them, that those people, they are at risk to develop severe COVID, which is our goal to try to avoid this progression as much or as powerful as we can. So as we say, the COVID is still there. So since December 2024, we still have like a lot of cases, as you see, a lot of reported COVID cases, more than 7 million deaths since the pandemic until December 2024. So that means, as we mentioned, COVID is still there. The aggressiveness, the mortality, the morbidity of COVID is still there. So we need to continue fighting. We should not stop here. And the respiratory viruses usually have like seasonal effect. So usually the majority of the respiratory viruses occurs in the winter season. So, and that's why we usually get our, for example, flu shot or the influenza vaccine, we get it from October to March, right, during the winter season. And after that, we don't get it. But COVID usually is all the time. We can see COVID in the summer, in the spring, in the fall, in the winter. It's all over the year. So that's why we need to pay attention to COVID more than the other viruses. And so someone will say, like, we already took the vaccine, so why we're worrying about COVID? So we are seeing a breakthrough through the vaccinations. The reasons behind that, as you see in the diagram, so the breakthrough of the COVID is either could be because of the immunity characteristics, could be because of our mucosal membranes is not that strong enough to protect ourselves from getting the virus. Could be because the vaccine parameters, some, you know, as you know, the immunosenescence, people after age of 50, their immune response is weaker than the other population. So this is also a factor. We have some immunocompromised patient around us, and this could be as a host-determined cause for getting the infection. Viral properties, if you remember, many mutants, it happens after the pandemic. We heard about Omicron, we heard about the England mutations. We heard a lot of mutations that happen. Some of them fatal, some of them is very aggressive and very fast to spread between people. So that's why after the mutation, the efficacy of the vaccines, it may go down. So this is the definition of CDC and WHO of the severity of COVID. So I want you to focus on the mild and moderate because this is our the target group that we need to focus on. So as you see, the mild COVID symptoms such as fever, cough, and fatigue, and the moderate is associated also with difficulty in breathing and mild pneumonia. And those people, they usually get recovery without hospitalization or any advanced medical care. So we want to pick those people and avoid them to progress to severe COVID, which is need hospitalization, and sometimes they need ICU and ventilation, and the mortality rate is higher than other population, such as the mild and the severe, the moderate. In the WHO, they usually just call it non-severe and severe. For the non-severe, as you see, 6% at risk for hospitalization and 3% for the moderate to be hospitalized. And the risk of hospitalization increase with the age and increase with some factors such as obesity, diabetes, cardiovascular disease, chronic kidney disease, active cancer, and those people that we need to pay attention to. Those people, they are the high-risk group to progress from mild to moderate symptoms to severe, which increase the morbidity and mortality, and that's what we are going to focus on the next slides. So these are, as I mentioned in the previous slide, the considerable proportion of population at high risk to progress to severe COVID. Age is the highest or the strongest risk factor. So patient above age of 50, and as far as we go in the age, the risk to move to severe COVID is higher than the other age group. Race and ethnicity is not as strong as the other conditions such as cardiovascular, CKD, COPD, and cerebrovascular, chronic liver disease, cancer, immunosuppressive patients such as transplant population, HIV, and etc. And we are gonna talk about each one individually. So if we talk about the diabetes in multiple studies, like if we start with the first meta-analysis, it showed like 35 observational studies with the diabetes, and the mortality and the morbidity with those patients is higher compared to the regular population. And even the other studies, as you are seeing, the mortality and also the morbidity, such as ICU admission, ventilation, all is getting worse. So in summary, individuals with diabetes, they are having high morbidity and mortality rate compared to the other group. So we need to pay attention to them when they are getting COVID. If we are talking about the cardiovascular risk associated with COVID-19 outcomes, so as you are seeing in the population-based cohort study was conducted in adults between age of 40 to 84 in England, and also is showing the same impact, that cardiovascular risk, if you see here, let's see, if you see here, like from hypertension, from first, they calculated a score for a cardiovascular disease called QRISK score, and if this score is below 10%, that's considered low cardiovascular risk, and if it's more than 10, will be called as a high risk. So if we see in between, every time we go up in that risk score, the progression to severe COVID is going to be higher. So we need to pay attention to those population. Even simple hypertension, they put them at risk to progress to severe COVID. The risk of severe COVID increase in patients with high BMI. Remember the first study that was published in New England Journal of Medicine, from first big trial, they were talking about cardiovascular, if you remember, diabetes, and they were talking about obesity. And since that time, obesity all the time is associated with poor outcome with COVID. So we need to pay attention to that. Obesity is usually associated with hospitalization. Obesity, you will see it is associated with using ventilation, ICU admission, and prolonged hospitalization in the hospital. Multiple studies as you see, were done, and one of the most important one, the one that was done in England in 2021, and it showed that, as you see, the number of ICU admission, ICU stay, the cost, the hospital cost is all worse if the patient BMI more than 30. Look at the last column. Is compared to the other columns, it's higher numbers, which indicates that obesity is a true risk factor that we need to pay attention to. Patient with cancer and face a higher risk to progress to severe COVID. And this is not only with COVID. Patient with cancer and using immunosuppressive medication, either biological therapy, chemotherapy, it alters their immune response to any kind of infection. And one of them is COVID-19. And once we are dealing with a cancer patient with any kind of infection, bacterial, viral, parasitic, fungal, whatever, we need to pay more attention because their progression to complication is higher than the other population, and their mortality is high because you are just using the antimicrobial agents without the help of their immune system, because their immune system is not strong enough to fight with you. So usually the immunocompromised patient, that's why they progress to severe form of the disease very fast. And as you see here, one of the studies that were conducted in the cancer patient, look at the Kaplan-Meier curves. You will see all the curves with cancer patients higher than the other population. If you look at the ICU admission, if you look at the mortality of the COVID, and if you look to the morbidity and the mortality is all higher, like assessment, hospitalization, ICU admission, mortality, all higher with cancer patients. So that's give us an idea, not only, as I told you, not only with COVID, we need to pay attention with cancer patients. Chronic kidney disease, and this is also a nationwide inpatient study was done in USA in 2020. They were comparing the patient with kidney disease free to the advanced kidney disease to the end stage, and also the same thing, the morbidity, mortality with the progressed kidney disease is higher comparing to the others. For example, patient with free of kidney disease, the risk is lower, but when we advance to chronic kidney disease, the risk will go up, and with end stage kidney disease, the people on dialysis or on renal replacement therapy, the highest risk is there. So chronic kidney disease, end stage renal disease, they are at risk to progress to severe COVID. Patient or people living with HIV are more likely to die from COVID, either with or without being a male, increase the age, more than 50, having malignancy on top of the HIV, chronic liver disease, heart failure, hypertension. Just having an HIV with COVID will put you at risk to progress for severe COVID. But if you add on top of it these other factors, the mortality here is very high. So that's why in my HIV clinic, usually one of the projects that we need to be careful, other than to give them their medication to make sure that their viral load is suppressed and they are on appropriate therapy, no side effects, blah, 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 we need to make sure that they are up to date on vaccination. We are doing as an excellence project in the clinic, that we have like a checklist of all vaccination. We are putting it, we don't let anyone to leave the clinic until we check all vaccines that he already took it, or at least we discuss with the patient and he agreed or he rejected it. And we are having a very high response rate of vaccination on those groups. as we mentioned, age is the strongest predictor of hospitalization and death in COVID-19. As you see, anytime we move to the higher age, the hospitalization will increase, and also the relative risk for death is getting higher as well. As you see, all the curves go to the right, and also the bars is increasing the time that age is increasing. As you remember, we have mentioned like a lot of things in the conferences. Remember when we talked about the RSV infection, anytime the age is increasing, the RSV severity is worse. Anytime the age is increasing, the shingles or the herpes zoster, it becomes like worse with a complication. So if we are noticing, aging is one of the very important factors in infectious diseases, and we need to be careful with it. And we have mentioned that in many events, immunosenescence here is the main driver for that. And we have mentioned it, what was the reason behind it, and why we are paying attention to those people. And sometimes guidelines, they just classify patients if you are more than 50 or less than 50. Vaccination, if you are more than 50, less than 50. For example, meningitis. The meningitis combo, it's different if you are more than 50. And if you are below than 50, it's another regimen. Vaccination, some vaccines, you are not allowed to take it if you are below 50, and you have to take it above age of 50. So that's why I'm just giving you more examples, just to pay attention to the age that is a good factor or a strong factor in infectious disease field. Okay, what's beyond the direct effect of COVID-19 in patients with underlying conditions? So here we were talking about what COVID will do on what the comorbidities will do on COVID. Like if the patient we have mentioned patients with diabetes, aging, CKD, cancers, HIV will make the COVID worse, right? So let's talk on the other hand. What COVID or any kind of infection will do on the comorbidities itself. So if we're talking about chronic illnesses such as hypertension, we are seeing a lot of infections, or even if you have a common cold, you see like your blood pressure usually is high, and at a certain time, if that infection is getting worse, that blood pressure will go down and will cause something called severe sepsis or shock. And sometimes with COVID or respiratory infections, if you have a COPD, you will go to COPD exacerbation. Some people with heart failure, they get worse, and they get heart failure exacerbation if they got infection, not only COVID. Cancer, the same thing, because those cancer patients and patients on immunosuppressive regimens such as transplant or autoimmune diseases, you know what they do when they get infection? First thing they do, they lower their immunosuppressive regimen medication, or they stop them. So what's going to happen? To help our immune system to fight the infection with us. So what's going to happen to the primary disease? Will exacerbate. Crohn's, patient on biological therapy, the patient will have Crohn's exacerbation, at risk for having Crohn's exacerbation. Patient, for example, with MS, like multiple sclerosis, they are on biological therapy, and they get infection, they get COVID, they lower down the dose, or they stop it. The patient will go to MS exacerbation. So it's you are trying to catch it from here, it comes from there. Diabetes, also a lot of studies showed that infection itself, remember, what is the most common cause of DKA, like diabetic ketoacidosis exacerbation or admission to the ICU after missing or non-compliance with the dose? Infection. Infection is the second most common cause of DKA, of hyperosmolar coma with hyperglycemia. So why? Because it increases the insulin requirements, and that insulin is not enough for that requirement, so the patient will become hyperglycemic. Okay? So it increases the insulin resistance. So usually infection itself, like in general, will do that, and COVID specifically, because some studies were showing that COVID itself will increase the risk of being hyperglycemic and increase the insulin resistance. A patient hospitalized with severe COVID at high risk of hospital-acquired infection. That's very important. If you are being hospitalized for anything, you are at risk for hospital-acquired infection. That's why I just before coming to here, I had a patient. He was like asking me, did the hospital did the right thing of discharging my brother from the hospital? He just came down from ICU and he stayed 1 day in the hospital and discharged. Is that appropriate? At least he needs to stay for about a week. Then he becomes stronger than he discharged. I'm like, no. The safest place for your brother is the home, not the hospital. Hospital is the most dangerous place for your brother because of these things. Immobilization, just lying on the bed, he's at risk for DVT. Putting needles, drawing bloods, changing secretion, he's at risk for bloodstream infection. Putting a Foley catheter, he's at risk for CAUTI, catheter-related infection. Changing the secretion, nurses handling 2 patients, not sure if we are having a sick patient beside him, so he's at risk for hospital-acquired pneumonia. The doctor came inside and with the rushing, he was called to see another patient. He didn't take like a very a good precaution to the other one. Now this patient, he's at risk for hospital-acquired infection, no matter what is the organism. So hospital is not a safe place. And that's why COVID increased immobility. That guy, he's in the ICU or he's in the floor. He's not moving. He's at risk for DVT. He's not moving, at risk for increased secretion, developing hospital-acquired pneumonia. At risk for a lot of blood sampling, a lot of blood tests, at risk for bloodstream infections. So being hospitalized for COVID is increased risk of hospital-acquired infection. And also, not even that. Now, look at this. So we are using a lot of antibiotics to those people. So beside getting the infection, you are not getting an easy infection. You are getting the most or the strongest infection in the world. You are getting the MDR organism, the multi-drug resistant, the difficult to treat organisms. And we are using a very difficult antibiotics, and we don't know if that's going to help or not. And a lot of them, such as colistin. Colistin is a very potent antibiotics, and we usually use in hospital-acquired infection. But it's a very nephrotoxic. And I saw a lot of people who used colistin, and they ended by having dialysis for the rest of their life. So it's not a luxury or not something like safe for us to stay in the hospital. Okay, so COVID-19, secondary infection, higher mortality than the people without the other infection. And this is also another study showing that patients with the secondary infection, they are having higher hospital stay, they are having higher morbidity, and they are having higher death or mortality. So that's why we are stressing on early discharge all the time. Like the good hospital is every day to remind their physician, discharge the patient that doesn't need, evaluate if your patient needs to stay in the hospital. If no need, discharge. Every day, assess the need of Foley catheter. You don't need the Foley catheter, take it out. Every day, assess if you need a central line. You don't need it, get it out. Every day, you assess if you need a ventilator. You don't need it, take it out. All of these risk for having infection, having more complications. The WHO continues strongly recommend Paxlovid treatment for mild to moderate. So as we mentioned, the high risk that we strongly need the Paxlovid, the people with immunodeficiency syndrome, and we have mentioned them, and such as organ transplant, HIV, autoimmune receiving immunosuppressive regimen. So it's strongly recommends to give those patients Paxlovid if they are presenting with mild to moderate COVID. But the one that we need to consider the WHO is asking us to consider using Paxlovid in moderate risk group, that people above age of 65, and as we mentioned, obesity, diabetes, chronic conditions such as COPD, CKD, and chronic liver disease, cancer, disabilities. We need to consider using them, and I will show you the MOH guidelines regarding those kind of people. So despite the demonstrated effectiveness and guideline, antiviral are underused. Yani we have mentioned like the efficacy, the benefits, and what is the consequences if we are not using it. But I think we need more awareness. That's why we are here. We are staying here in this room to have more awareness to ourselves and to the other medical staff that please catch those people as early as you can. Determine them. If they are your target, start the Paxlovid as soon as possible to avoid more complications. And that's what we are doing here. And we are showing that we are still behind. A lot of people, like less than 50% of the adult above age of 65 of outpatient diagnosed with COVID receive the recommended antiviral medication. So that's why many factors, we will talk about them in the next slides. So one of them, the early diagnosis. So once you suspect COVID, please do the testing. Please target your goal. Just pick the disease, do the PCR, do whatever is available in your hospital to find the diagnosis as early as you can. Because early diagnosis in all infectious disease field, it will decrease the mortality. Remember, like in sepsis, if you are delaying the diagnosis and starting the antibiotics, the mortality will increase about 7% per each hour. كل ساعة نأخر فيها الانتيبيوتكس, every 1 hour we delay the antibiotics and delay the diagnosis, the mortality will increase by around 7%. And the same thing here, because we will talk about like why the time it matters in Paxlovid. So early detection and treatment of very important to prevent severe outcome. So in the WHO, the recommendation is to give the Paxlovid within the 5 days of developing of the symptoms. So that's why we need early detection of the disease as soon as possible, and as soon as possible determine your target. Just put the classification for your patient. If your patient is in mild to moderate and is high risk to develop severe COVID, such as immunocompromised patient, it's strongly to start Paxlovid. If they are in the moderate risk group, such as cardiovascular, COPD, chronic kidney disease, consider using it. And in our MOH guidelines, they are asking us to use it. Okay, so we have mentioned that. Just do the testing, whatever is available, diagnose the case, positive people, start the medication as soon as possible within the duration. So the antiviral treatment is predicted to reduce the viral transmission. So it's not only like one of the benefits of adding the antiviral, it improves the symptom, the severity of symptoms, it prevents, the progression to severe, so it improves the symptoms. And also it improves or it decreases the duration of the disease. So instead of the COVID to stay for 10 days, the duration, we will see it in the next couple of slides, 2 to 3 days lower than the expected time. So it improves the duration and the severity of the symptoms. And the most important one, hospitalization and mortality. So let's talk about the most important trials that proves the efficacy of the Paxlovid, which is EPIC-HR phase 2. So EPIC, this is E for evaluation, P for protease, I inhibition for the high risk group population for Paxlovid. So the study was the main objective to evaluate the safety and the efficacy of the Paxlovid in the non-hospitalized mild to moderate. And the treatment was to give the Paxlovid, as you see, 300 milligram every 12 hours for 5 days. And the selection criteria, age more than 18, confirmed, and symptoms less or equal to 5 days with one or more than sign of symptoms of COVID at the day of randomization, and more or equal to one characteristics or coexisting condition associated with high-risk progression, as we have mentioned in the previous slides. And let's see what happened. And as you see, it's just like almost one-to-one randomization. The primary endpoint to look at the hospitalization and the mortality up to day 28, and we have secondary endpoints. So here are the demographics of our patient. As you see, we picked our patient above based on the inclusion criteria. And as we see, the BMI were like the number of more than or close to 2,000, smokers, hypertension, like variety of comorbidities. If we see like the group at comparing the placebo to the Paxlovid, we were seeing like a great effect. So mortality almost zero, not almost, mortality is zero, and improvement and hospitalization were statistically significant compared to the placebo group. So hospitalization, which is morbidity, and mortality were statistically significant decreased in the Paxlovid group compared to the placebo. And here, as you see, the hospitalization at age of 28 and the patient treated with less than 5 days symptoms. Also, the Kaplan-Meier curves, it's much better in the Paxlovid group, and there were no mortality were noticed there. So the Paxlovid was associated with reduction of severe COVID across the various patient group. Here, if we did like a subgroup analysis, we will notice the same effect in elderly age group, in male gender, in obese patients, in patient diabetes, hypertension, and immunocompromised, that people on monoclonal medications. So all groups were associated with low morbidity and low mortality as well. So the Paxlovid was associated with reduction also in healthcare utilization. So if we are decreasing the morbidity and decreasing the mortality, what is the end result of that? Less hospitalization, less hospital stay, less using of antibiotics, less developing of resistance, less low number of complications. So the patient will be discharged home very quick. So all hospitalization based complication will be decreased in this group as well. So the Paxlovid safety profile has been also consistent with the clinical trials. So multiple clinical trials were done, and in the EPIC-HR also they were assessing the adverse reaction, and there were no actually major adverse reaction compared to the placebo group, and less than 2% incidence of serious adverse reaction that needs to discontinue the medication. So in terms of efficacy, the medication was effective. In terms of safety, the medication was safe. Those two factors, they are the major factor for any medication that you want to use in any field. You need effective medication, not also effective. If we want to be very precise, we need cost-effective medication and safe to use. Paxlovid can be used in a certain or special population, yes. So the most important one that we always want to make sure before using any medication is that medication safe with a renal impairment? Is this medication is safe with a liver impairment? Is this medication safe with this medication that the patient already on? So with a kidney impairment, it's okay to be used without any dose adjustment if the GFR more than 60 and below 90. Renal impairment between 30 to 60, we need the dose should be adjusted, but in GFR less than 30, it should be avoided. With a patient with liver impairment and severe with the child book class C, we should not use it. Otherwise, we can use without any dose adjustment. We are using a booster. Usually ritonavir is a boosting to make the medication more potent and more strong. And once we are using ritonavir or protease inhibitor in general, they have the potency to be a microsomal enzyme inhibitors. Microsomal or cytochrome enzyme inhibitors, that means I'm inhibiting other medication to be secreted from our body. So they are at risk for developing toxicity. So be careful when you use this medication to check all drug-drug interaction with the Paxlovid to make sure we are not falling in a complication. I still remember one of the patients we were using ritonavir. It's one of the anti-HIV medication, and the patient was taking Symbicort inhalers for asthma. He became Cushingnoid because of that. It was a very potent microsomal inhibitors. And that patient, after 3 months, he came with a Cushing syndrome because of that. So they are very strong microsomal inhibitors, and they are at risk to develop toxicity from other medication, especially in immunocompromised patients that they are on biological therapy, they are immunosuppressive regimen, they are on antibiotics. For a serious infection, we don't want to harm the other medical condition that the patient already on. On the other hand, also, we want to make sure that we are not using other medication that can increase or decrease the level of the Paxlovid. So it's vice versa. So we need to make sure that Paxlovid is not harming other medication and the vice versa on the Paxlovid. Other things, anaphylaxis, Steven-Johnson, the toxic epidermal necrolysis, these are the things that if you see it, we should stop or discontinue the Paxlovid. We have mentioned that we need to focus on both sides, on the Paxlovid group and on the other medication. We don't want any toxicity, or we don't want to decrease the efficacy of the other medication because of the interaction. So always, always, always check the interaction between the Paxlovid and the other medications. Real world evidence, I will move just very quick on these. Just in summary, these are a couple of studies. After the trial, it's just supporting the efficacy and the safety of the Paxlovid as well as EPIC HR have mentioned. So here is the first one. It was showing the Paxlovid were having an excellent impact on the patients with comorbidities and decrease the mortality and the morbidity at the same time. And the other studies also checking on the hematological malignancy, autoimmune immunosuppressive regimen with people with solid organ transplants. And as we are seeing the numbers, they are very positive outcomes when we use the Paxlovid in those group to avoid progression to severe COVID. And here also the other studies are showing if the patient are receiving the Paxlovid within the 5 days, the diagnosis and the duration of the symptoms, the improvement, the progression to severe COVID, all decreases either in hematological malignancy or in the other groups. Safety, also these are studies on the safety showing that more than 90% of the reported cases were non-serious, consistent with the serious adverse reactions, and also supporting that the EPIC HR and EVIC standard risk studies that showing there is no serious adverse reaction were noticed in the study, and the other studies were supporting the same thing. Let's just summarize. COVID-19 pandemic is over, but we are still dealing and handling COVID patients. Beyond the direct effect of COVID, the patient underlying condition face significant additional risk, as we have mentioned. Despite the effectiveness and the guidelines, we are still underusing antiviral such as Paxlovid, and we are overusing antibiotics, and we have just mentioned that. Early detection is very crucial and very important to target or to reach to our goal, because early detection means we are gonna hit the duration of 5 days, and once we hit the duration of 5 days and we determine our population, we can use the Paxlovid right away. And RCTs, we have just mentioned, the EPIC-HR showed that Paxlovid is effective and safe to be used, and the real-world evidence supporting the EPIC-HR. And very quick, this is our national guidelines, and if we look to the mild to moderate symptoms here, they are asking us to consider the Paxlovid, but in the Saudi guidelines, they are one of things, they just decrease the age. Remember, in the EPIC, the age was 18 and more. But if we look in the Saudi guidelines, in the bottom is 12 and more. So they are considering and they are giving us the chance to using it even if the patient below age of 18 and above age of 12. Exclusion criteria, also here I would just like stress on the age of 12. These are the exclusion criteria, but above age of 12 we can using it. And thank you.
Thank you so much, Dr. Mohammed, for this very illustrative presentation. You have taken us in a journey exploring where we stand here out of COVID pandemic and how we are handling our perceptions towards our community. You have highlighted the risk populations and the impact of COVID on those people at risk, and the COVID with comorbidities and how it is react. And then finally, you have landed into the treatment with Paxlovid, and you have shown us the evidence that support the efficacy and safety. And finally, we had a recommendation from Ministry of Health regarding the use of Paxlovid. So thank you so much. Now we would like to move to the second speaker, Dr. Tarat Termisani. He's a consultant family medicine and geriatric and in Al-Baha University, and he has been an activist, in fact, in participating with us under the umbrella of Saudi Society for Family and Community Medicine, with a lot of contribution to this kind of activities as a speaker. So his topic today is going to be very important, and it will shed light on the other spectrum of the ecosystem that we are living in towards handling the COVID, which is the vaccine hesitancy and vaccine fatigue, and the vaccine recommendations, which we are supposed to, interact with. So I would like to welcome you, Dr. Tarad. And Dr. Tarad, he was supposed to be with us here today, but he will be online. So I will just leave the floor for you, Dr. Tarad, if you can hear us, please.
Assalamu alaikum wa rahmatullah. I can hear you.
Yes, thank you.
Okay. Assalamu alaikum wa rahmatullah jami'an. Good evening, everyone. First, I want to thank you all for either attending virtually or physically. And I want to thank the Saudi Society of Family and Community Medicine, FIX, and our sponsor for tonight's event, Pfizer, for giving me this opportunity to join you all tonight. Today, I'm going to be speaking about the vaccine hesitancy and fatigue management in the older adult population. And before I proceed, I want to thank Dr. Mohammed Samanoudi for his very informative lecture. So first thing I want to move on, I'm going to put some present my highlight. So this is going to be the outline for tonight's lecture. I'm going to give a brief introduction and a background of what we call vaccine hesitancy and fatigue. Then we're going to take a global overview and perspective about the vaccine hesitancy and fatigue. Then we're going to narrow our vision more into our region of the GCC and Saudi Arabia and how is that impacting us. Then we're going to talk a little bit about the factors influencing the vaccine hesitancy and fatigue in the older adults community in Saudi Arabia and what strategies to combat that hesitancy and fatigue. Then the conclusion. So when we talk about can you see the screen? Okay. So when we talk about the vaccine hesitancy, it's generally means that there is a delay or refusal from the patient side of taking the vaccine, even though it's available. But what does fatigue mean? Fatigues mean that patient already took the vaccine, and even though the patient will need a repeated dose to maintain um, a good immunogenicity toward the of the vaccine in the system, they are fed up, they are tired, and they are burnt out. And there is many reasons for that. So these are basically the definitions of vaccine hesitancy. So having a problem to initiate taking the vaccine, even though it's available, and fatigue because of the burnout of receiving a lot of information and because of overselling of the uh, vaccine information to the older adults, they get tired of it and they refuse to take frequent booster doses because of that. And actually, vaccine hesitancy is a problem that was recognized by the WHO in 2019 as one of the top 10 strategic burdens and barriers in the older adults and globally. The importance of aging population in the context of COVID-19 is very crucial because 90% of COVID death globally occurs in those who are 60 and above. So let's take a quick look at the global overview and how did the world do concerning that in terms of vaccine hesitancy and fatigue. So since the vaccines was introduced by the end of 2020, so in December, there was an excellent pickup of the vaccine globally. Almost like two-thirds of the world population received the vaccine in its series as an initial dose. And we can see that in the United States, in the European Union, and in East Asia. But after that, after completing the first dose, second dose, or third dose, and the recommendation of taking booster doses was rolled on by the health authority in different parts of the world, especially for the older adults. We've started to notice that there is significant drop on picking up on the vaccine and taking the booster dose. So there is almost like at least 20 to 40% drop of older adults proceeding with receiving the booster doses. Then this is what we call again the fatigue. And again, there is a lot of reasons for that. We're going to talk a little bit about them. Some studies looked into that and they compared the data of 23 countries, seeing what are the reasons for the hesitancy to begin with. And it seems that there is a global theme of reason for the hesitancy, where we can see that up to 60% of people whom they didn't receive the initial series dose, they had concerns about the side effects of the vaccine. And of course, this is not the only thing that we notice about the COVID-19. This is a very common phenomena and theme for all different kinds of vaccines. After that, the lack of trust in government or health system, let's say, the belief that the COVID-19 is not serious, well, up to 25 to 40% of people were thinking that. The misinformation and conspiracy beliefs, especially in the era of social media, um, and there's a lot of misinformation going on. And you won't be surprised to see this trend to be growing more and more over the upcoming few years, because you can see such information being spread by, let's say, the officials in the one of the biggest healthcare systems in the world, which is in the United States. For instance, the health minister of the United States, RFK, he debunked the benefits of vaccines, and he promoted that there is no significant benefit from that, and the opposite is that it may promote different diseases according to him. So also the low perceived personal risk. So people may think that since we are sitting at home, especially for the older adults who they are bedbound, so they don't go out, they perceive that we're not at risk, we don't need to take the vaccine, which is not true. So the fatigue form actually from getting the series of booster doses after that started to grow after the year 2022. But what about here in Saudi Arabia? So in Saudi Arabia, let's take a look, first of all, of how did people perceive vaccination? And let's take the influenza vaccine as a milestone before the COVID-19 pandemic and after that. If we look at the GCC area, we can see that Saudi Arabia, the pickup of the vaccine was very low, less than 40% in the population. But after the COVID-19, there was a significant improvement of picking up of the influenza vaccination, especially in older adults. And we can compare that with the United Arab Emirates and the Kuwait. We still see that trend where older adults start to focus more in taking up on influenza vaccination. And we can see that reflected also in the COVID-19 at some point, but not exactly. The reason is behind that. If we take a look at this graph over here, we can see an excellent pickup, as Dr. Ashraf Amir mentioned at the beginning, that we reached what we call the herd immunity for the first time um, during the pandemic, especially because of all the legislative and logistics bring up and the governmental regulation that being put in place to enforce everyone to take the vaccine. But unfortunately, we saw that there is a trend of very slow pace of picking up on the booster doses of the vaccine, especially for the highly needed population. So population whom are at risk or the older adults. So 23% had received the booster in the early of the 2022, but almost like 68 of the total population fully vaccinated by February by that time. But the booster dose pickup was very low. And we looked into the reasons why would the global population wanted to take the vaccine. And we wouldn't be surprised to see that the same reasons that was reported globally for people not to take the booster shot for the COVID-19 is also repeated in Saudi Arabia. So let's take a look. What are usually the factors influencing the patient hesitancy and fatigue, especially in the older adults? And for that, there is a framework from the WHO that looks into what are the 5 reasons for vaccine hesitancy. So, and that looks into the first C, which is confidence. So, is there a confidence between the patients or population in general and the healthcare authority? Or is there a confidence between the patients and the healthcare professionals? So, doctors, nurses, dietitians, health educators, so in general. Then it look into the calculation. But before we move into the calculation, it's worth mentioning that according to different meta-analyses here done in Saudi Arabia, the confidence between the healthcare professionals and the older adults is very high. The older adults in Saudi Arabia, they trust the Ministry of Health and their recommendations. Then they trust the healthcare professionals. And this percentage reached up to 80%. So when you put that in contrast to what they usually see in the social media, you can easily debunk any rumors with good education and addressing the patient concerns, which are actually are very reasonable concern. So the second thing is the calculation, weighing the risk and benefit of taking the vaccine. And this is actually very important. The way Dr. Muhammad Samanoudi explained how the disease may impact the patient morbidity and causing mortality. There is also other aspects I want to bring in here is that the quality of life can be impacted um, in a big time, especially for the older adults if they get admitted to the hospital. Their admission in the hospital, getting discharged from the hospital, they need a very lengthy journey of returning back to their baseline. And for myself, as a geriatrician, I focus on three things. I focus in making sure that my patients are independent on themselves as much as possible. Secondly, I want them to live the highest quality of life as much as possible. And thirdly, I want to prevent them from getting admitted to the hospital as much as possible. So, putting the risks of not taking the vaccines for the older adults, enlisting all that, not just for the COVID-19, but all different kind of vaccines is very convincing for them. The third C is convenience. Is it easy to get the vaccine or not? So even though there was a lot of investment in the infrastructure, especially in technology of making things easy for the older adults to book an appointment with the primary healthcare centers or any healthcare provider they prefer, still they face a very difficult time um, proceeding with such technologies. So, especially for the older adults who are sitting at home, is it convenient for them to leave home, especially they are bedbound, and to go to the primary healthcare center to receive the vaccine? It's actually extremely difficult. And here comes the home healthcare services or the mobile clinic, where they should make this pretty easy. So the barriers to get the vaccine actually is pretty significant. Technological, distance, finding the appointment. So creating something that would make the experience and giving the appointment for the vaccine is very crucial. Complacency is the vaccination being seen as a low priority. And this is what happened since at the beginning of 2022. So what happened is that since the news about the SARS-CoV-2 starting to wane off and become in the background, and people were getting tired and stressed out and having anxiety about the pandemic, they tried to forget everything about the pandemic, and so they tried to avoid relating anything in their health concerning that period of time. And so, even if we offer the vaccine for them, they will refrain from uh, agreeing on taking the vaccine for many reasons, either because of what they saw in the social media or they have someone they know who suffer from a side effect, which we all know that all vaccines have a general side effects and a local side effects. So all these things together will refrain those patients from being compliant with the vaccine and agreeing to take it. So the collective responsibility, willingness to protect others, again, someone who is sitting at home, especially for the older adults, they don't perceive that there is any need for them to take the vaccine since they are isolated from the outside world. But again, this is not true. So when a study was published looked into the top reasons for the COVID-19 vaccine hesitancy among the older adults in Saudi Arabia. So this table here is pretty similar to the one we saw earlier, looking into the percentages of the reasons of vaccine hesitancy globally. But in Saudi Arabia, it was the fear of side effects, which was about 27 up to 42%. So here, when we start talking to our patients about the importance of getting the vaccine, we need to explain to them and emphasize that yes, there is side effects to the vaccine, but again, these side effects are the same side effects of any other vaccine, and they're limited. Usually, they stay between 2 to 3 days, and they can take, let's say, paracetamol to control any symptoms of any emerged. So doubts about the vaccine safety and efficacy, and of course, that was a very hot topic over the past couple of years, looking into whether or not the vaccine is safe or not. We need to say something here. We shouldn't be denying that there was some incidents happens across the world because of some concerns of the safety and efficacy of the vaccine. But also at the same time, we need to emphasize that the vaccine that being provided by and purchased or provided by the Ministry of Health and the Kingdom of Saudi Arabia, they're targeting the best and highest quality of vaccines. And so not everything that they hear or see in the social media are true. So low perceived risk. So again, they're homebound. 10% of people they have hesitancy or fatigue of taking the booster shots because of that. Lack of trust in the vaccine. Again, we see this um, globally in a highest percentage than in Saudi Arabia. Misinformations or myth, again, in the social media, WhatsApp groups, family network. And here comes a very important part of the whole chain, which is the family member. Patient may be on very excellent medications, not necessarily I'm talking about vaccine, but any other medications that may help in controlling their chronic conditions. Unfortunately, family members may uh, advise their brothers, sisters, especially if they're elders, not to take too many medication that may be beneficial for them, or they know someone who started the medicine that caused some side effects. So this is very important to educate the whole family. So physical logistics, access barriers, about 8 to 12% of patients in Saudi Arabia. Again, it's worth mentioning that the level of trust between the healthcare professionals and the older adult in Saudi Arabia in comparison to other healthcare systems is pretty high. Okay, so we talked about the different the framework from the WHO and the 5 Cs. And again, we need to into how we can fix the confidence. We need to empower the providers to answer the safety and efficacy questions. And here comes um, the importance of education. What we're doing here tonight is very important because when we empower ourselves with more informations of how we can um, answer the questions and the concerns about without dismissing the patient concern. We need to embrace that first of all, and we tell them yes, some of the informations we need to dissect these informations and misinformation that they have, and we need to answer them one by one in a scientific way. Complacency, so personalized risk reminders. This is a little bit outside the clinic encounter because this will need implementing a very sophisticated EHR or electronic health record system where we keep reminding our patients about the importance of taking their vaccine, either for the COVID or for the influenza or for any other vaccine like the RSV, for instance. Convenience, so making the walk-in appointment easier if possible, because for some patients, when they try to book an appointment through the application, let's say Sahati, and they see that maybe for them, since they're ready now to take the vaccine, but their appointment will be after a couple of days, or maybe for any reason, either the vaccine is not available or anything similar, they may postpone this idea of taking the vaccine for unknown time. So making it very easy with a single click, booking a schedule in order to get the vaccine is very important. Drive-throughs, home vaccinations, um, all these things should help the patient hesitancy and being reluctant to receive the other doses or any other vaccine beside that. Combining the vaccination, so encouraging patients to take the COVID-19 vaccine along with the influenza vaccine. So taking multiple vaccines should make it also easier for the patient. Calculation, giving infographics, flyers, comparing the risk of ICU admission versus the vaccine adverse events could be very convincing for the patients. And the collective responsibility, so messages to the family and younger adults that they need to take the vaccine in order to prevent the disease moving into their loved ones sitting at home. So basically, we looked into the global perspective. There is a lot of burden and fatigue, uh, most probably and reportedly because of a lot of information that being giving to the older adults about the importance of vaccination. So the strategy should be retailored again. This should be done in a multifaceted way at the level of the encounter in the clinic, organization level, at the country level. So different strategy needs to be approached here in order to fix that problem. The reporting of the number of cases of COVID-19 is very important because we do still have pockets of some surge, especially before Hajj season. We saw a spike, even though it wasn't reported at some level, but it is there, as Dr. Muhammad Samanoudi mentioned, and we need to protect ourselves and our loved one, especially with the surge of the chronic diseases and to lessen the burden on the healthcare system. This should conclude my presentation to you all. Thank you all for being patient, and thank you.
Thank you so much, Dr. Tarad, for this wonderful presentations, which highlighted a very important part that could enhance and promote the good uptake of the vaccines. So now I would like to invite Dr. Muhammad to come up on the stage. And Dr. Tarad, you'll be with us to receive the questions. And we have been privileged to have our colleagues who are online with us. There are more than 1,000 attendees, and they have sent me many of the questions. But I would like to give you the privilege of giving us the questions from you as physically attending audience. So I will open the floor. If you have any question, please, you have the mic. Any questions? Questions? Dr. Nawas? Okay. طيب. Mic, please. Can you give the mic? حط صورة الدكتور.
Since I'm the victim always.
No, you're not.
Regarding it is very beautiful. I mean, when Dr. Mohammed mentioned that, he gave us a very good panoramic view. And really, I appreciate your aggressiveness. I think this is very important because relying on some sort of giving a time or frighten of some, whether to invade anything else. I think it's to go ahead hard with antibiotic and 7% of mortality. I think that is a huge number. So what you recommend from the different aspects? Okay, we start the management. Would you like, to go for positive lifestyle in combination with the therapy? Your recommendation regarding get a patient outside of the hospital for the best. So what shall we recommend for those patients when they are outside?
Okay, so one of the things that I would like to mention, if you are seeing, we are working very fast and very hard of developing more diagnostic testing, such as molecular testing. You will see we have a lot of models, such as like we have blood multiplex. It's just like a data of blood organisms, and we are just like putting a sample there. And once we are putting a sample there, it will tell you which bacteria that sample it match, which DNA it match, and this is the results. So you are dealing with E. coli in the blood in less than half an hour. Meningitis multiplex. You just put a drop of C. diff on this multiplex, on this kit, and in a couple of minutes, it will tell you you are dealing with the Streptococcus pneumoniae culture. So you will stop all the antibiotics, just keep the vancomycin and ceftriaxone. We are having also a stool multiplex. We have a lot of diarrhea, and you don't know what are you dealing with, and in a second, you know that this is salmonella. So once we are having those fast things, so you just like get them out of the hospital if we have a medications, and during staying out of the hospital, we have to make them safe and make them protected from other people to get infected. It depends on what kind of infection you are dealing with. It's either you are in the hospital. If they need isolation, just isolate them at home. If they need just a droplet isolation, just tell them to wear a mask. Like, try to make their life also easy and protective as much as you can to just accommodate them outside the hospital.
I assume you are to go ahead with even for triple antibiotic.
Yeah. If we are discharging patient with osteomyelitis on triple antibiotics. Sometimes with culture negative osteomyelitis, I cover all the bases, such as gram-positive, gram-negative, and anaerobes. Sometimes I reach to 3 antibiotics. Yes, I don't mind at all.
All right.
I may change, to Dr. Trad, regarding this kind, old age, which is very critical, and GFR, what is your criteria for giving some sort of strong antibiotic for those aged people?
Thank you very much for your question. Before I answer this question, I just want to return back to the original question too. So as Dr. Muhammad Samanoudi said, hospital is not the best place for anyone, especially for the older adults, to stay there for many reasons, causing delirium, nosocomial infection, and etc., developing DVTs. So, and I know that Dr. Muhammad is also sitting in some of the committees that focuses on OPAT and discharging patients from the hospital on a suitable antibiotic to treat these infections. So usually any home healthcare that is very established, either in governmental side or also the private sector, can help and ease the transfer or down step from the hospital admission of a general ward down to the house. And you also asked about what can the patient do in terms of, getting quickly to their baseline. Usually, if the patient is stable enough, they can start the physical therapy at the same time in order to, regain what they lost during their hospitalization. Concerning the second questions, for the older adults, we don't have like a contraindication specifically for the older adults in taking some of the antibiotics, especially if it's a life-saving. As you mentioned, unless there is a real issue with, depending on the pharmacokinetics and dynamics and kinetics of antibiotic and how is it going to be getting rid of out of the body. It's worth mentioning here for us as geriatrician, we don't usually rely on just the creatinine level to estimate the kidney function in order to adjust the dose of the antibiotic according to their need. We usually go with the creatinine clearance. So the GFR, it's very important. You need to calculate that if it's not reported in the labs in your institution. You need to make the calculation according to the weight and the age, because you will be surprised that even though the patient have a normal creatinine level, but their GFR will be less than 60. So this is something, of course, that we need to be special attention to.
Okay, thank you so much, Dr. Tarad. I think I have a question for you, Dr. Muhammad, regarding how effective is the Paxlovid against the current variants of SARS-CoV in terms of the new variants that's circulating. Is it effective?
Yes, it's very effective, and the current mutation, it doesn't affect the efficacy of the Paxlovid, so it's effective against the majority of the mutants, which is the most current one, the Omicron.
Omicron.
Yes, so it's very effective.
Any other circulating variants coming up apart from Omicron?
Yes, يعني a lot of variants. Every day they are studying, but for now, no any like major threats. Like
Okay.
majority of mutants or variants, they are just like affecting the spread, not the mortality too much.
Okay, thank you so much. Dr. Tarad, there is a question from the audience who were online. What communication strategy have proven most effective to counteract hesitancy? So the communications strategy.
So the first good thing is that there is an established good trust between the healthcare professionals and the patient in Saudi Arabia, and you can build on that. Usually what happens during the encounter, especially with the older adults, so they come with a very long list of comorbidities, a long list of medications, and you focusing into that. You have a very limited time in the clinic to address everything. So usually we don't tend to think about the vaccines as one of the things that we need to talk to our patients to. But when we keep in mind that we have to put the immunization, the same thing that we talk to families, parents about the pediatric immunization, we need to talk about the geriatric immunization. We need to incorporate that during any visit, even if it's at the end. So when we start talking about that, first we need to know what vaccination they received before. And from there, if you start introducing the vaccine immediately, you might get blocked out, honestly. So first of all, you need to ask about the history of vaccinations of them. Then you mention if there's one of the vaccinations are not taken, let's say influenza vaccine or the RSV vaccine, you need to incorporate that this is something that was recommended by the Ministry of Health. So, and this is going to give you an anchor to make it very easy for the patient to open up and accept. And because, again, most of those patients, they will refuse vaccines because they have misconception uh, and a lot of methods that they have either from social media or WhatsApp groups. So when you throw the image, honestly, name over there, you're going to give this anchor of credibility along of the patient's confidence in Saudi Arabia on the healthcare professional. Then you're going to receive the questions, and they're definitely going to ask about the side effects and the efficacy of the vaccine. Here, you need to mention that the benefits. So you need to do the calculation of the patients. Most of patients, if they see you recommending the vaccine, they will get convinced about that. But what happens is that if we have ourselves as healthcare professionals, we have this inner misconception of the vaccines themselves. We won't be recommending that. So education to the healthcare professional, incorporating that as a part of any visit of an older adult. If the hospitals can incorporate an alarm for the physician to help them identify patients who didn't receive the vaccine, it will be very helpful. And again, be ready and open to embrace all the patient's concerns. Don't block them. Let them say everything that they have in mind. Then we need to reassure them. We have the data. We have the support of the Ministry of Health as a supervising body for everything being approved and given in the kingdom. We have our goal toward a healthy prosperous society. We have our goal toward uh, longer life expectancy. All these together should convince the patient to receive the vaccine.
Thank you, Dr. Rad. And I would like to mention here that it's our job to believe that vaccination or vaccine are very powerful tools that could prevent, mortality and morbidities and safeguard our community. And in fact, we have to learn how to counsel patients, in fact, who have some kind of vaccine hesitancy, because it's an art or skill, soft skills that we have to learn within the limited minutes of encountering with patients. We have to learn how to utilize those minutes and make sure that we deliver the proper communication to convince the patient and to convert the patient perceptions toward the vaccines. And I truly believe that vaccines should be there in all encounters regarding the specialties, even if you are doing some specialty far away from vaccination. But again, you have to learn how to promote vaccine, how to enhance the uptake of vaccinations in your institutions and wherever you are. So collectively, we can forward and direct our patient to the vaccination clinic, and then we will get the objective that we would like to have. طيب, Dr. Mohammed, there is another question for you. Any biomarkers or clinical predictors help to identify patients who would be benefited most from Paxlovid?
So the most important one is the CDC and the WHO. These are the strongest evidence that we should all follow, as we were following the MOH, and the MOH, they are depending on those recommendations.
The risk of antiviral resistance emerging with increased use of Paxlovid.
So for now, up to now, we don't have these things, but as an infectious disease, yes.
Yes, it might
there
happen.
is a risk. Yeah, that's the
So if there is
pathogens are
any
very smart. Yes.
there isn't limitations to use Paxlovid?
Yeah, usually no, and usually the resistance for the viruses is extremely rare.
Okay.
The bacteria is smarter than the viruses.
Okay.
Usually it's very difficult and very hard to develop a resistance in a virus.
Any actions towards the stewardship, regarding this antiviral?
Yes.
Okay.
So that's why we said if positive, that's the only time to use it, but don't use it empirically.
Okay.
I don't recommend
Perfect.
using it empirically.
Right. Dr. Tarad, a question for you from the audience. How do we handle patients' questions about the evolving nature of mRNA technology and the long-term safety?
Okay, this is an excellent question, because some of the people perception was, even from a very renowned scientist, they were promoting that the biggest human experiment was done during the COVID-19 pandemics with introducing new technology. But again, we need to know that this technology is not that new, honestly. But it's been established for many decades, but it wasn't introduced, let's say, in a broad way until the COVID-19 happened, and there was a significant urge to come up with vaccines quickly. But again, it's not a new thing. It's not a totally new technology. It's been going on and was studied very well over the past couple of decades. And there is new applications going on, and more studies, not just for as a vaccine, but as an antiviral vaccine, but for other conditions like a malignancy too. So um, of course, this is a very also valid question, because we shouldn't be denying the fact that some of the patients who receive the vaccine, and we see that in the clinic in a daily basis. So some of the patients, they develop maybe some side effects that wasn't known before, like idiopathic urticaria. Again, we need to receive these questions. Millions and millions of hundreds of millions of people receive the vaccine. That doesn't mean that side effects shouldn't happen. It can happen, but again, the majority of patients did very well. It was a very life-saving vaccine for during the pandemic. And this is an area of research now, but again, it's not new.
Thank you so much. Dr. Tarad, as a geriatricians, definitely you are encountering a problem of vaccine hesitancy among your elderly populations who are very difficult to convince. And knowing that these populations of group, they require to have multiple vaccinations, almost 5, 6 vaccines, you know. So how do you tackle this kind of hesitancy in that particular group who are very difficult to convince, yet they require more vaccination than any other populations?
Thank you for your question, because this is totally true. So the older adult vaccination start with the 50, even though 50 years old is not considered like in a geriatric age group, but starting with the vaccine against the herpes zoster, we start talking about such a vaccine. Um, Again, we introduce, for myself, I introduce the vaccine. I start talking about the prevention, uh, but I don't get frustrated from the beginning if from the first visit the patient said no. So what happened is that uh, they will hear from you. They will say, let me think about it. This is very typical. So they will say, let me think about it. They will go home. They will ask their friends. They will look into the social media. If they see, and there is a lot of positive things like the Ministry of Health vaccination campaigns for the older adults, um, asking any healthcare professional in the family, testimonials, or any older adult influencer, let's say, they will see these things in the media that will make them, when they come in the second visit, they will mention the vaccine that you talked about to them in the previous visit. So don't get frustrated from the first time. Just introduce it and put a schedule for them and combine it as much as possible so they don't get frustrated because of that.
Excellent. My last question for you, Dr. Tarad, how many vaccines can you give at a time for your geriatric populations, for your geriatric people? How many vaccines you can give at one single encounter at a time? And this is one of the modalities that we encounter. You know, we handle it as a strategy to not to have a missed opportunity of having that particular patient who require these kind of vaccines in one visit. We give multiple shots. So how big? Because I have encountered in one of the military recruits, they give 7 vaccines at a time, 4 and 3, 7. Yeah, okay. So I come encounter and I saw it myself. So how about you, Dr. Tarat?
Okay, so let's assume that we have a patient who's completely ready to receive all the vaccines. So how we can combine these vaccines? So it's a little bit different. So we return back to the manufacturer and the recommendation from the Ministry of Health with Saudi FDA concerning that. Let's talking specifically about the SARS-CoV-2 COVID-19 vaccines. You can combine that with the influenza vaccines. Taking also a look at the RSV vaccine. You can give the RSV vaccine with no problem along with that. But concerning the let's say the herpes zoster vaccine, um, um, I'm not pretty sure, but maybe Dr. Muhammad Samanoudi can help with that. Because the number of vaccines that we can administer, so we have the herpes zoster, we have the pneumococcal vaccine, and then we have the 20 now. So it's going to be very helpful instead of giving the patient the 13, then the 23, after that, a year after that. So we can easily combine most of these vaccines unless it was contraindicated by manufacturer, but I cannot recall anything that contraindicated.
Okay.
Of course, you need to give it not in the same side for some of these
Yeah.
vaccines, and you need to give
Absolutely.
the herpes zoster in 2 doses.
Yeah, sure. My last question for you, Dr. Muhammad. Any evidence that early outpatient treatment with Paxlovid reduced the risk of long COVID?
Yes, so some observational studies, they are talking about that. And also, if you see, they are decreasing the duration of the symptoms of the acute, and also some of the observation studies, but we didn't talk about it here. It decreases the long COVID. Yes, that's true.
Okay.
And a lot of upcoming studies talking about that. And regarding the inactive vaccination, we do have like a rules in infectious disease that you can give up to 3 vaccinations inactive without any problem in the same visit.
Okay.
And we usually don't like to combine more than one life attenuated vaccine per one visit.
Yes. All right. I think this was the last questions. And before we end, I would like to ask the 2 speakers to give us one recommendation, one single recommendation from you, Dr. Mohammed, regarding the importance of using Paxlovid in a short window of 5 days for mild to moderate cases of COVID patients with those people at risk. So what is recommendations for our colleagues in the primary care?
Try to be ready all the time for your target, and early detection is the most important part.
Thank you so much. Dr. Tarad, another statement from your side regarding vaccine hesitancy, vaccine fatigue, and vaccine recommendation.
Don't be tired and fatigued from incorporating vaccination. During your visit, discussing that among all the different comorbidities with the older adult. If it doesn't happen in the first visit, don't worry. The next visit, be very sure that patient will return back to you asking about the vaccine when they can take it.
Thank you so much, Dr. Tarad. And coming to the end, I would like just to conclude that the COVID-19 pandemic is over, but still the virus is there and the infection is there. And we encounter on our day-to-day practice in primary care and family medicine and even other specialties, patients who are coming with COVID. And I think we have learned that there is special risk populations that we have to identify among our total populations of patients that we encounter every day. We have to know that the early interventions to treat patient early stage with mild to moderate COVID using Paxlovid, which has been proven to be efficacious and safe and tolerable. We have to make sure that the drug-drug interaction has to be considered. Otherwise, we are going to provide the patients with the safe medications that could be, save our patient from hospitalizations, from deteriorations and severe complications. Again, we have come to shed light on the vaccine hesitancy and the vaccine fatigue. And I think this is the state of art of all of us as a primary care physician, that we have to develop our skills and we have to be vigilant enough to identify those people who have to have the vaccine. We have to generate an ecosystem within our institutions, using our nurses in the triage to ask patients according to the age and according to the risk, whether they have taken those vaccinations or not, and then they can initiate the process. You have to utilize the International Awareness Days for any disease and keep the vaccine as one fixed campaign that has to be incorporated with all the educations campaign that you have across your activities as a healthcare provider. With this, ladies and gentlemen, I would like to thank you for being with us till the late hours of tonight. On your behalf, I would like to thank our guest speakers who have been quite informative and rich in their updates and giving us their thoughts and expertise. Dr. Mohammed Al-Sabanoudi and Dr. Tarat Al-Misani. And I would like to thank Pfizer Company for giving us this wonderful opportunity. And I would like to ask them, in fact, to give us more and more about this very interesting topic. A special thanks goes to FEXIS for the wonderful organization of this. And I would like to thank the online attendees who have been with us, more than 1,000. And thank you for the wonderful questions that I have received from them. And this is not, shed a light that we have a quality questions, that we have quality audience, that they are giving us this kind of interested questions for this kind of discussions. Till we see you again, ladies and gentlemen, I wish you a good day. Fi amanillah. Okay, yeah, sure. خلفية كويسة. دكتور طراد انت معنا. دكتور طراد you're going to be with us for the photo. Okay,
Sure.
you ready?
يعطيكم العافية جميعا، شكرا لكم. تعبت الجواب.
والله بخير المشروع. لا صعبة. لا هي صعبة. لا صعبة. افتح حق الله يا عمي. ايوه نعم.